It's showing live.
I request
Sure, sure.
ma'am to stop the sharing and give me 1 minute, just 1 minute. Yeah, Shakur, Dr.
Yes, sir.
Chandra, please stop the sharing for a moment only.
Uh,
There we go.
Yeah,
yeah. Thank you so much, ma'am. Thank you so much.
yeah, Shakur,
So,
we're all set.
yes, sir. Thank you, sir. Thanks for your support. So, good morning, Dr. Sandra. Thank you so much for joining us, and good evening to all of the participants over here. Thank you so much for joining today's international webinar session, uh, which has been organized by Department of Pharmaceutical Technology, JISU University. It's really a pleasure to have all of you and to get a great response in the registration for this webinar session. I would like to request all of the participants that please put yourself on the mute mode during the session. So as our speaker with us right now, before she starts her presentation, I would like to give a brief introduction about her. So we are having right now Dr. Sandra Leal. So Dr. Sandra Leal serves as the Executive Vice President for Health Plans and Payers Division of Tabula Rasa Healthcare, that is TRHC. Tabula Rasa Healthcare is a leader in providing patient-specific, data-driven technology and solution that enables healthcare organizations to optimize medication regimens to improve patient outcomes, reduce hospitalization, lower the healthcare cost, and manage the risk. Basically, it is a patient service provider providing company in a different aspect. Dr. Leal has been senior executive at I'm so sorry, senior executive at Sanofi RX, prior acquisition by TRHC, where serving as Chief Executive Officer, Chief Operating Officer, Vice President for Innovation. Before that, she was also associated with El Rio Health Center, where she was Medical Director, Director of Clinical Pharmacy Services, and Residency Director as well. Dr. Sandra holds a Master of Public Health from University of Massachusetts, Amherst, and a Doctor of Pharmacy degree from University of Colorado School of Pharmacy. If we talk about her publications, she has published and presented her work in numerous national and international publications venues such as Peru, Saudi Arabia, and Japan. She has been recognized as the Good Government Pharmacist of the Year by the American Pharmacist Association for her advocacy of pharmacist provider status, received two Pinnacle Awards for her progressive practice innovation, and received the ASHP Best Practice Award. So this was a very brief introduction about our speaker, Dr. Sandra Leal. Our department is really privileged to have her with us right now. So before Dr. Sandra starts her presentation, I would request all of you put yourself in the mute mode as she can give her presentation without any obstacles. At the end of the session, there will be a question answer session. You can put your questions in the chat box, and I'm sure our speaker will be very happy to answer that. Now I'll request Dr. Sandra, ma'am, if you please proceed with your presentation and share your screen.
That sounds great. Well, thank you so much, and good evening, everyone. It is a pleasure to be here to share my experience and then to talk a little bit about what I'm going to do as president of the American Pharmacists Association. I've been very active with the organization now for a number of years, and the reason that I became so active with the American Pharmacists Association was to advance the role of pharmacists in the healthcare team. And there is no better and what's happening now with the pandemic to see the value and the essential work that pharmacists have in the front lines, helping patients have access to their care, to treatment. We're just about to start the vaccinations here in the United States. We're actually already rolling out the flu vaccine, and then we are changing legislation actively as we speak about allowing pharmacists to vaccinate children, and then also test for COVID-19 and to administer the vaccine for COVID once it becomes available. So there is a lot of incredible work happening right now as it relates to pharmacy that's really putting us out there to be able to be effective leaders in healthcare. So I wanted to share a little bit about what I do on a day-to-day basis. I'm excuse me, the executive vice president for Symphonia RX, and we are a division of Tabula Rasa Healthcare. This company really uses technology in healthcare for everything that we do. And it actually, this company started at a university, at the University of Arizona College of Pharmacy. So what we did there in 2006, this company started when the government changed the rules here in the United States to allow for medication payment as part of the Medicare program, which is our federal payment system for our patients that are 65 and older. So this program started, and it required that a pharmacist or another healthcare provider do comprehensive medication reviews for patients to offer them as part of that service. And so that's what started this company. And we quickly realized that there was a significant need because we see so many issues with patients taking medications that we really had to leverage our ability to do this nationally. So this started in Arizona. That's where I'm at currently. I'm in Tucson, Arizona. But this company works nationally, and we actually also have international opportunities with the work that we're doing. So I'm going to advance the slide here. So just a little bit of background about Tabula Rasa Healthcare. The company I mentioned earlier, Symphonia, was started in Tucson in 2006, but in 2017, we were actually acquired by another company called Tabula Rasa Healthcare, which just expanded our ability to use technology and grow into other areas, all medication related. The person that founded Symphonia and the two people that founded Tabula Rasa Healthcare are all pharmacists. So all of our leadership in our chief positions are pharmacists, which is great because all of us really focus on how to use technology to be able to address adverse drug events and then resolve those problems for patients by using data that we're receiving from patients, by health systems, and we make interventions to impact care. So the headquarters for our organization is now in New Jersey, but we have offices in multiple states across the United States. We have, the one in Arizona where I'm at. We're in Colorado, California, Florida, Iowa, Minnesota, Missouri, Ohio, and Texas. And we continue to grow because there's such a need to address the medication-related issues that we're finding. And just this past year, in 2019, we also started a precision pharmacotherapy research institute. So we do a lot of work on a medication risk score, which is essentially a risk stratification where we identify the risk for patients and the interactions that they're experiencing, and then assign a risk score that we then try to improve. So the risk is between 0 to 50, 50 being the worst. And what our goal as we're making interventions as pharmacists is to get that risk score to decrease so that patients have less adverse drug events, less hospital admissions, and we're actually able to impact the total cost of care for the healthcare system and the patient if we're able to intervene on that. We have over 1,500 employees now, so growing quite quickly. And we actually work with universities and colleges of pharmacy. We've actually grown. We started here in Tucson, but now we have relationships with other universities and other colleges of pharmacy where we have clinical call centers, and we work with the faculty at the universities, the students that are at the university, and we also work with the research teams at the university to show the impact of the interventions that we're making as we're resolving problems, but we're also making interventions and then growing the opportunity to improve care also. So we love working with universities because they bring so much diversity in student populations. It allows for us to provide access and language support. with the 8 universities that we have, we're able to have about 27 to 28 languages represented. So when we're calling people across the United States, we're able to reach them in multiple languages because we have a diverse group of students that can reach out and a diverse group of pharmacists that can reach out to the patients that we're reaching. I'm not sure what happened here. Let's see. We currently have another relationship where we also have our technology in community pharmacies. So as pharmacists are dispensing in the community, we use our technology and our clinical dashboards, our platform, to be able to identify the patients that are coming in so that we can also be proactive in reaching them and making sure we're resolving problems. So what's really important about that is that we're reaching people in different ways. So not just calling them with telehealth and technology, but we're also locally at the pharmacy reaching patients using the data that we have. And currently, between all our relationships, we serve about 100 million patients in the United States. So about 1 in 3 patients are impacted by our technology and the interventions with our pharmacists. So this is just a little bit of the footprint of where we're at. So we work very closely with payers. These are insurance companies that pay for the healthcare insurance for patients. So over 350 payers, that impacts about 10 million patients. I mentioned earlier, our technology is in 15,000 community pharmacies right now with the 100 million patient reach. And then we also work in a different program. In the United States, we have a program called PACE, which is the Program of All-Inclusive Care for the Elderly. So we're in 70 PACE centers. That is impacting about 13,000 patients. And what the PACE program does is it's a program where people who are very, very complicated would end up in nursing homes. Instead, what we're trying to do is work with PACE programs to keep people at home and prevent them from having problems or having falls or any type of risk that would end up leading to a hospitalization or a nursing home. So we're trying to keep people at home and keep them safe so that we can reduce the total cost of care. So we really use the risk score that I mentioned earlier to improve care, reduce errors, and then hopefully have better outcomes for those patients so that they don't end up in high cost acute situations. So I'll talk a little bit more about the safety and why we really focus on this. So one of the things that we always worry about is medication errors. Medication errors happen all the time. This is when something is prescribed inappropriately. So that happens, but what we're also worried about is the adverse drug events. And this is when harm happens to a patient, even when the medication is prescribed normally. So this is a little bit different in the sense that we're not just identifying medication errors and trying to resolve them, but we're also using things like precision medicine, pharmacogenomics to be able to test the patient's genome and identify whether or not they will metabolize the drugs appropriately, or whether or not they're going to get a high dose from what would be a normal dose or a usual dose, I should say. So we're starting to really take different aspects of pharmacogenomics, sedation, anticholinergic activity. All of those things are the things that build our risk score. And then we're able to target those so that we can also find the best medication for the patient instead of just what's usually recommended, but the best medication for that patient based on their liver enzymes, on their CYP, on all the different aspects that make that person. And that's how we're also able to make more precise recommendations for that individual. So we're really moving more into the precision medicine, pharmacogenomics aspect of care, and not just addressing the things that we always look for, which is the medication errors. So we here in the United States have been measuring for a long time how much it costs us. How much do these drug events cost us? They cost us quite a bit. So when we looked at the spending versus a drug illness in the United States, the RX spend for medications has gone up dramatically. You can see from 1995 to 2016, the increase, and that's the green bar, it's gone up dramatically. So this is in billions, so $450 billion in drug spend. And then what we see is that for every dollar we prescribe, we're actually seeing almost another dollar in error. And we see that adverse drug events continue to increase if you add multiple medications. So on the right side over here, you can see if you have 2 or 4 or 7 medications, the chances of having adverse drug events increases significantly also. With 2+ medications, you have a 13% increase, 4+ medications, 38%, 7+, 82%. And that ends up costing so much money in hospital visits, in the emergency room visits, and then in hospital stays. So when we're trying to justify the role for pharmacists, and what we do is we intervene and we resolve these problems so that we actually improve and have a good return on investment for the interventions that we make. And that's the argument that we continue to make to our government and to our communities about the value of pharmacists and why it's so important that the pharmacist is always part of the care team, and that we're not just at the back end when the prescription has already been written, but we're actually part of the team before the prescription is written, so that we can help make recommendations based on the data that we have, based on the pharmacogenomics that we have, to make a better recommendation about what medication the patient would benefit from that would actually result in a better outcome, not a worse outcome. And so that's, again, the argument that we make. And that is why I actually ran for president for the American Pharmacists Association, because here in the United States and in many other countries in the world, pharmacists still don't have that recognition of the value that they bring consistently. We have to show that we have consistent value and that we always need to be part of the healthcare team and not just an afterthought after they, after patients already have the medications. So this is when we look at the difference with the reviews. This is a little bit of a graphic on showing what happens with healthcare costs, adverse drug events, hospital admissions, and ER visits if a patient does not have a medication safety review. We actually see an increase or a worsening of all of these different metrics that we're measuring. And we measure these consistently with the data that we're receiving from the health payers and from our government. What we've done is we've actually done our interventions and we've looked at these same metrics and we see what actually happens when we make an intervention. So in the green, you can see what happens with medication safety reviews and the reduction in these costs. We actually see a 6.5% reduction for healthcare costs, adverse drug events reduced by 14.8%, hospital admissions by 21%, and then ER visits decreased by 6.1%. So if you actually add these all together, you're really seeing almost a 50% swing in some cases, hospital admissions, a 30% reduction plus a 21%. That's actually a significant shift in the total value of what we do when we make interventions and we actually impact the patient in a positive way. And this is constant. We have to measure this all the time when we're talking to payers and to our government and to our policymakers, because they always want to see the data and they want to see a measure of what we're doing. So we do measure quite frequently and we share this and we publish. Right now, we've published about 30 articles just this year alone on the interventions that we've made in multiple cases to show the value of what we do. So just to give you a little bit of background about what's happening in the United States. So this is pretty current. I just did a check in this month to see where we're at with legislation. And in this year alone, we have had a lot of momentum with provider status and the ability for pharmacists' scope of practice and recognition to increase. There are 147 bills in our Congress, in our state legislation that are advancing the role of pharmacists. I mentioned a couple of examples. Just this past month in August and September, the Department of Health and Human Services in the United States allowed for pharmacists to start vaccinating children from the ages of 3 to 18. And we had some ability to do that for adults. And in some states, for some children, depending on the age, some states had they had a cutoff of like 10 or higher or 6 or higher. But what this change did federally is that now all pharmacists across the entire United States can vaccinate anybody 3 years old and above. And the reason for this is because of COVID, and because we want to provide more access points for children and for families to be able to have their kids vaccinated. We've had a lot of people not going into medical offices because they're afraid. And so what this does is that they go to their pharmacist, they go to their pharmacy for medications. So this is now allowing pharmacists to vaccinate without having the restrictions that were in place before. That's just one example that happened in the last 2 to 3 weeks. Another example is that we just passed a bill, and this is again in the last 2 weeks, where the pharmacists in the United States are going to be allowed to provide the COVID vaccine as soon as it's available. And then we have been able to do COVID testing with our scope of practice. So a lot of the changes have been very positive because of the pandemic. And we have been advocating very, very significantly about how we have, again, played essential roles in access to care, in advocates for patients, when a lot of the doctor's offices have been closed and have been providing telehealth services. So pharmacies have become an area where people go for clinical services. So we've tried to increase the momentum on that and make sure that the rules are permanent once the COVID pandemic is over. We want to continue the flexibilities of what we've received today so that they continue post-pandemic. And so that's one of the things that we're actively advocating for and that we're fighting for, to be able to do that from now moving forward. So just a little bit about how we use the technology and the data that we have. So just if you look at the graphic that I have here, one of the things that we've developed is a risk stratification tool and some clinical. So what happens in these scenarios is that we get data from the health plans and from the health systems, where we get demographics for the patients, we get medical claims, we get pharmacy claims. And from that, what we identify based on clinical rules that we built is we identify interactions that are the highest risk, and then we risk stratify the patient to know which patients are the most critical to call immediately, because we're finding out that they have some of the worst interactions or potential adverse drug events. And then from that, we actually work on a med reconciliation. A lot of times it's directly with a patient, sometimes it's with a provider, sometimes it's with both. And then from that, we're able to provide the medication review consult. And so the beauty of the technology piece is that we don't have to physically be sitting next to the patient anymore. We can actually provide a clinical consult from anywhere in the United States to anywhere in the United States. And this has been tremendous, because if we identify a person in a rural area that doesn't have access to a provider, we can call them and actually provide the access, and we can call them in whatever language they need support in, and we're able to identify and address those issues and resolve them. And then we work with their providers to make sure that that issue that we found is actually resolved. So we don't just talk to the patient, we actually make sure that we communicate with a provider to resolve the problem. And so if you see that prescriber engagement, if necessary, that's what we do. And then we'll follow up with a patient if necessary to make sure that what happened continues to be addressed. Our technology is also great in that anytime that the patient refills a prescription, we do a check. Our technology actually checks their profile again to see if any other errors are being introduced. So all of this technology, the platform that we created and the dashboards that we've created, identify those problems so we can continuously identify and resolve the problems to reduce the errors for the patient. And then again, all of the things I've already identified: total cost of care, ER visits, healthcare costs. Or the other thing that we do is that if we find a patient has a certain condition where they're not being treated, but they should be, we also look at the national guidelines for care and make sure that the person is getting the right treatment. So for example, if we have a person who has had a heart attack or who has diabetes and they should be on a cholesterol medication like a statin, and they're not, we identify why not. If they had a drug event in the past or an adverse drug event, then we identify that. If they should have been, but they just were never prescribed it, there was some sort of fragmentation in care, we make sure that that person has the right prescription to prevent any future heart attacks or strokes, because we're identifying what gaps in care they have based on the national guidelines. So it's not just that we treat for prevention of errors, we're also looking at gaps in care, national guidelines. We're also looking at cost barriers because some patients, even though they might be on the right regimen, they might not be able to afford it. And so what we do is we work really closely with the patient and the provider to make sure they get a regimen that they can afford and that they can continue to take that meets the therapeutic goals for that individual person. So it's constantly an evaluation to make sure that all aspects of their medication use is appropriate and that they're receiving the medications for the right reasons without interactions and without error. So it's a lot of things we're evaluating as we're making these interventions. So just so you know, this is the statistics from last year of what we did as far as interventions across the United States. We currently support 28 languages based on that diversity of students and our pharmacists. We also have a telephonic translation line in case we have a language that we don't actually have a person for, but 28 are the ones that we have immediately now. We make over 20 million calls a year, and these could be telephonic. They could also be telehealth with video like we have now with Zoom. Last year, we completed close to 600,000 comprehensive medication reviews. And these CMRs are the ones that qualify based on our Medicare contract, our federal contract. So these are the mandated type of reviews that are required for our elderly population. We had over 100,000 daily communications and numerous interventions based on the identified problems that we found, over 5 million, close to 6 million interventions. And these are the different technologies that we use. We use voice technology, texting technology. We have also developed an app for patients to be able to access their local pharmacists that can do these reviews. We email patients, and then we've started to use social media also for outreach because people go to social media. So we want to make sure that we're also in the places that they're going. So we're not expecting patients are able to come to us always, but we're trying to find ways to get to them no matter what platforms they're in. So, you know, I always look at these numbers because it's just incredible to see this. You know, in the United States, we have heart disease. We have 647,000 people that die of heart disease, cancer, and then adverse drug events is really significant. But we don't classify that as one of the leading problems a lot of times. A lot of times adverse drug events are buried and we don't have the statistics that come out, but we're looking at specifically what significance this is in the United States. And it's a significant problem that we're seeing with the growth on that. We also look at some of the estimated deaths, and you can see some of the deaths that are caused, like in 2017, 70,000 people died from opioid overdose. And that's another problem in itself that we're also intervening and trying to tackle. In 2021, it is estimated we're going to have 200,000 deaths from adverse drug events. And a lot of these are preventable, things that we can identify, that we can address if we proactively review medications, speak to patients and providers to resolve them. You know, I'm looking at the numbers of adverse drug events for this. And unfortunately, with COVID, we're also seeing a number of patients die. You know, in the United States, we are at about 200,000 deaths now for COVID. And a lot of the deaths, we're now starting to see that could have been associated to some of the initial use of medications, not understanding how to treat it. So we're currently doing research and reviews on the use of some of the medications like hydroxychloroquine to see what impact that had, if it actually helped or hurt in the treatment of COVID. And then how do we continue to treat patients moving forward? So even in this pandemic, you can see the importance of understanding the medication, how to dose it appropriately, and whether or not it's indicated for a certain condition. So that's another thing that we're tackling right now as we're dealing with a pandemic as we speak. So this is my last slide, and then we can open it up for questions. But I just want to talk a little bit about the community piece. This is where the pharmacists in the community are really incredible and have outreach. We talk a lot about medication adherence, but not just people taking the medications. It's about people taking the right medications. And so when we're doing medication adherence as part of our company, it's not just that people fill the prescription and take it, but that the pills that they're taking are the right pills for the right conditions. And a lot of times we see that people are just being told, take your medication, but unless they're actually being reviewed for appropriateness, it's sometimes not good to be adherent to the wrong thing if you're not on the right medication. So that's just something that was just constant education that we have to provide for our healthcare providers and for the system in general. I mentioned earlier that we use multiple channels for digital communication to be able to do this. Right now with the pandemic, we've seen an incredible boom in telehealth. And so we've leveraged telehealth, and we've been doing telehealth since 2006. So this isn't new for us, but for a lot of providers in the United States, this was the first time ever that they had used telehealth, and they weren't comfortable before. Now everybody's pretty much getting comfortable with it because they've been forced to use it. So we're going to see that healthcare and how it's delivered is going to change post-pandemic. We're seeing that now, but we're looking at how it's going to continue post-pandemic and what kind of blend of telehealth and local interventions we're going to have moving forward. One thing that isn't changing is the importance and the value of data. You know, data is key. If you have the data for a patient, you're able to evaluate it and look at how to, on the data, it really helps you identify population health strategies. So you are looking at an individual patient, but then you can also look at an entire population and identify trends and areas where people have challenges in accessing care, and then we provide the care. The documentation that we provide is very critical. We like to share our data with electronic health records, with the providers, with other systems, like I mentioned earlier, with apps. The more information we have about patients as it relates to their care, hopefully that reduces a fragmentation that sometimes happens, where you might see a specialist and they only have some of the information, and then they go to their primary care doctor and then they only have half of the information. Then a person goes to the emergency room and they don't have any information. So we're trying to create more interoperability where everybody has information about the patient, especially the patient themselves, so that they can share with everybody and that person has their information communicated so that there's an error avoided. I already mentioned the importance of like reaching for people with social media for education. We're using a lot of Facebook Live, education classes, things like that. And this is what I want to just spend a little bit of time in. And like I mentioned, this is my last slide, so I'll open it for questions. But one other area that we've been focusing a lot on is also making sure people have their vaccines, you know, definitely for flu season every year, but all of the guidelines for vaccines for people with diabetes, for pneumococcal vaccines, this has been something critical. And obviously with COVID, making sure people have access to COVID and understanding that they need to take it. We've also started working a lot on disease management and wellness support. One of the programs we launched this year is a diabetes prevention program that's also available through telehealth. And the reason for diabetes prevention is because I'm sure that you're also experiencing the same problem that we have here, is that 1 in 3 people in the United States has pre-diabetes. And I know in China and India, we're seeing incredible rates of diabetes. So we started a program where we're using interventions to prevent diabetes so that people don't develop diabetes. So if we find a person who has risk for diabetes, either they have multiple family members, or they have hypertension, or they have cholesterol, we identify those patients who access our education remotely, either in video, telephone, to be able to do health coaching for them so that we can reach the patient throughout the year to make sure that they lose weight and that they stay active to prevent diabetes. So this is a significant investment because we don't want people to end up having a chronic condition that's so expensive if we can prevent it. But even when they have diabetes, working closely with them to make sure that their numbers are controlled so that they don't end up having complications from lack of control. So these again are just the ways we're reaching patients with technology through telehealth to do this, because before go into a class 26 times for our diabetes prevention program, which is very difficult for people when they have, you know, all these barriers to care. So we're trying to bring education to them instead of them having to come to us. And that's how we're leveraging technology to do that. So with that, I will thank you for your time, and I'm wanting to see if you have questions about what we spoke about and what conversations we can have about the presentation that I just provided.
Thank
And
you, Dr. Sandra.
I have the chat box open if you want to type a question or if you want to speak. I will be reading both.
Great. So thank you, Dr. Sandra, for this lovely presentation and a lot of new information we have got to know about TRHC. So I'll request all of the participants, please put your questions in the chat box, or else you can unmute yourself and ask your question directly to the speaker. So till now, we don't have question. We may be having very soon. So I have a question, Dr. Sandra, that I'd like to know that how TRHC, the institute you are associated with right now, that they to the self-medication errors to be dealing with that.
I'm
Ma'am,
sorry.
you're muted. Yeah.
Yeah, you cut out. Do you mind typing it in the message box? Because it broke up and I couldn't catch the first part of it.
Sure. I would type it.
Okay.
Ma'am, we have one question by the time in the chat box. I think you can see it also. It's from one of our students. While doing the clinic trials, was usually don't test the drugs over a pregnant woman, and in future the drug may show major the fetus. So in that case, is there any solution of minimizing this thing?
Yeah, that is, I mean, that's a significant challenge, you know, when the clinical trials are usually very restricted about the populations that they're doing their research on. One of the things that we're looking at with this too is the use of pharmacogenomics with medications. And we're labeling a lot of the medications now in the United States. There's close to 200 medications now that have pharmacogenomics labeling on them. And so a lot of times what we can identify is based on the mother's genetics, how that might impact the child or how that might impact how they would metabolize medications. But this is a hard question because nobody really wants to take the risk of testing pregnant women and then having, you know, an adverse drug event or a birth defect on the children. So this is something that I think with precision medicine, we will be able to do more of that without testing or having to test pregnant women directly, but through the science of knowing the pharmacogenomics of the child, we can hopefully minimize the risk this way. And so this is going to be evolving, but I think that's a great question that you asked because it is very complicated. You know, we, in general, even when we think we know the safety, we still try to recommend pregnant women not to take things just because we want to be extra cautious with them.
Right.
So I see another question here. What are the steps on creating a telehealth app of my own after I get after you graduate? There is so much. I mean, that's a great question. There's a lot of people that are doing a lot of entrepreneurial kind of you know, they're doing design of their own applications. So there's a lot of ways to do this. You can do it on your own if you have the technical skills with HIT that you can actually develop your app. The other way that I've seen being successful is to partner. We use a lot of collaboration here with our students. When I said that we partner with universities, a lot of the universities that we partner with have an IT department, or they even have an MBA program where they have business background. And we actually create relationships with these different groups to be able to leverage what their successes are. So if we have a great IT department and a great business department, even marketing, we can actually get a group together and start designing something together that we then, you know, develop. And then when we're working with other groups, other organizations, we can also create partnerships that allow for us to use their software to do that. So the telehealth app industry is really interesting because there's so many opportunities right now. It is kind of a very competitive field. So I think one of the things to think about is if you have an idea, is find somebody that you can partner with to help you develop it. And then one of the things that we always talk about immediately, especially here in the United States, is to have your idea copyrighted or patented so that it doesn't, somebody doesn't steal it from you, because that's always a concern that somebody's going to take your idea and then, try to make it their own. So that's always an aspect of what you're doing, to try to be careful so that somebody doesn't take it from you.
Thank you. Thank you.
So how does TRHC handle the adverse drug reactions generated in case of self-medication and patient non-adherence to medication? So self-medication, one of the ways that we've tried to address the self-medication is that one of the apps that we developed allows for people to put the medications that they're taking that are not prescribed. So if it's something that is an over-the-counter medication, or even things that are not considered medicine necessarily, they can put it into the app and it'll still do the drug interaction for them. The good thing is that I mentioned earlier the score. We have a score that's 0 to 50. So that score is something the patient can see. If the score goes up, that tells them not to take it. If the score goes down, that's okay. Or even if the score stays the same. So we're also educating people that if they're going to take something and it makes the score go up, that's risky and that they shouldn't. They can actually link to the pharmacist so that the pharmacist can make a recommendation for a different item that might be safer for them to take. So that's how the self-medication works. Now for the non-adherence to medication, we actually get the claims data for the patient. So we're able to tell whether or not they filled the prescription based on the claim data, which like every month, if they don't fill it, we would know they're not taking it. And so we take that non-adherence information and we work with them to identify why not. Is it because they had a side effect? Is it because they couldn't afford it? Is it because they just don't want to? I mean, there's a lot of reasons, but we know when they're not adherent based on that refill information so that we can actually work with the patient to identify what they are willing to take and what makes sense for them. So that's how we use that technology. Great questions.
Okay. Right now, we don't have any more questions. So, okay. So, Dr. Sandra, if we have more questions upcoming, then I would like to send that to you through email. I'm sure that would not be a problem for you to answer that through email.
No, not at all. I have, if my slides on the end, they have the my email. I'll actually share the screen again. So if you have any, here it is. If you have any questions, I also am very active on Twitter and LinkedIn. If you have any of those connections, you feel free to, connect with me on those, because I do post a lot of information related to medications, technology. So I'm constantly, active. And then my presidential year, I'm president-elect this year. In March of this coming year, I'll be president of the American Pharmacists Association. So we'll have a lot of, discussions going on as it relates to that and to advancing the profession for pharmacy here. And we do, we're working with FIP and all these different national groups to be able, international groups to be able to advance pharmacy globally too, not just in the United States. I do see another question here.
Yeah.
In this pandemic, many of the people are taking hydroxychloroquine without any prescription, without any idea of its adverse effects. So how much harmful may it be? It's kind of interesting. We're finding out right now, we're starting to see some of the data come in. And there was a recent published study here in the United States where they're looking at this information, and they are starting to see some consequences of hydroxychloroquine, especially combined with antibiotic mortality. So I don't think we have the full answer yet on this, but we are seeing that in some cases it doesn't help, and in some instances it might hurt. So as that information is being shared, we are in the United States making recommendations to the doctors not to use it. Hospital systems have now said we're not going to use it as a treatment protocol, but obviously with more information, we have more ability to do that. In the beginning, everybody was trying to do anything. So there was great hope that it was going to help. but hopefully people are, cautious about it, because we know that it has some QT issues with the heart and some other problems that we're concerned about. And so the other consequence of hydroxychloroquine being used is that people that actually need it weren't being able to access it. There was actually a shortage that was being caused for people with a real need for it. So there's a lot of different consequences of this when we start doing something without real information. So again, this is again a real important reason why pharmacists need to be involved. And we need to really look at the science and the literature to understand what the real benefit or not is of this particular medication and others that are going to be used.
All right. So Sandra, I have one more question to ask. With a reference of the last question you have given the answer about hydroxychloroquine. In India, our Indian government has declared that the hydroxychloroquine can only be taken by the healthcare workers or the person who are directly working with, in contact with COVID infected patient, or the contact person with COVID-19 patient. So, is there some kind of regulations in the United States of America about hydroxychloroquine?
So in the United States, we didn't make that recommendation. That didn't go through. I know that initially there were
Okay.
some groups that were starting to study it. I actually saw the University of Minnesota here put out a study where they were actually doing like a protocol for healthcare providers to try it. But pretty quickly after we
Right.
started to see some of they pretty much said, we're not really seeing a benefit. And so that went away. We've also been tracking the World Health Organization and looking at other countries that had COVID earlier, like China, South Korea, and trying to learn from their experience to see what we could use as information for our healthcare providers. We were struggling with things like protective personal equipment where we couldn't get enough to protect the healthcare workers. So we had so many things going on. But as we're learning more information, one of the things that we're doing now is evaluating even the COVID vaccine and the protocol on who's going to get that first, who's a tier 1. And obviously healthcare providers that are on the front lines will be tier 1 for vaccination to get it immediately, because they're obviously treating all the people that are sick. So we're working on that. But with hydroxychloroquine, we didn't have a formal protocol in the United States because there was just so much information and it was conflicting. So we didn't do that collectively as a government.
There's one more question for Sandra. That being the leader in the world in healthcare, how US is dealing with the COVID-19 situation?
Well, it's been very challenging. We've had so many deaths. Almost 200,000 deaths here, which has been a tragedy for our citizens of the United States, but then also for the physicians and the pharmacists and everybody in the front line, the nurses. We've had a lot of deaths of our healthcare providers also. Last I looked, and it's been a while, we had over close to 700 healthcare providers die as a result of COVID. So it's been very challenging. The personal protective equipment we had a shortage. And then we have states here in the United States, and within our country, the different states have had COVID handled differently because the governors of our states have also had different ways that they've implemented how treatment happens. And so we've had some groups that have been more successful than others. And so one of the things I think that has really helped has been the masks, having people really mandate mask use. And we started to see a decrease in COVID. My state, Arizona, for example, we were one of the worst in the world for a while. Our state actually at one point was such a hot spot. And it wasn't until the local mayors, when they started to implement the mask mandate, that's when we actually started to see COVID drop. So a lot of it has been political opinions, people on different sides. That has resulted in whether or not certain things are adopted or not. So I think that it's been complicated because of the politics of it versus truly looking at the science, the information that we're getting, the experience of other countries that have influenced how COVID has been treated. We have a disagreement in a lot of areas about how effective we've been at managing it. And it is political, unfortunately. So question here, as a pharmacist, do you really think that after passing all the stages of clinical trials, the COVID-19 vaccine may come within the end of the year, which is being claimed by many of the vaccine manufacturers? You know, I think that there will be some vaccine available, but like I said, it's going to primarily be for healthcare providers. I don't think we're going to get a lot of vaccines for all of the people. I think there's going to be delays in that just because there's not even, I mean, we have just in the United States, and you also have so many people, right? We have 330 million people here. We're only looking at about 30 million doses that they think they're going to be able to provide. So it's only going to be that much. And I was in a different meeting yesterday, and they said that they're looking at the minimum effectiveness of the vaccine that they're producing is it has to be 50%. So effective. So it doesn't, just because we get a vaccine doesn't mean it's going to be 80 or 90%. It's only going to be 50% effective, hopefully more, but that's the benchmark that they selected. So now we have a vaccine that's only going to be in, say, 10% of the US population and only 50% effective. You still have to have some of the other precautions. I think the mask use, like I said, it really impacted the decrease in transmission. So if we are smart and we continue to use the masks, if we continue to work on the vaccines, and then flu vaccine, making sure people are also taking flu vaccine so that they don't end up overwhelming the hospitals with flu on top of COVID. I think those are strategies that are going to start to improve the pandemic, but it's so variable because so many countries are taking different approaches, and we're starting to see, I think Israel is doing a second lockdown, and then some European countries are already starting to see spikes again. So when we get comfortable and we start forgetting the importance of some of the mask mandates, we start seeing spikes again. Our university here in Arizona and in Phoenix, they opened and they were trying to put kids back in school, and we started to see hot spots again. So it's when you're not being, cautious or making decisions that are based on science that we start to see the spikes go up again. So it's got to be balanced like that, but I don't think it's going to be a vaccine that's going to be readily available to everybody immediately. It's going to take some time just because of the sheer volume of people that would need to be vaccinated to be able to do that effectively.
Thank you, ma'am. There's another question from our faculty member, Dr. Momita Ray. She first wants to thank you for the session. And the question of her is how much initiative is taken nowadays for cosmetic vigilance and material vigilance apart from pharmacovigilance?
I am not too involved with cosmetovigilance or material vigilance apart from pharmacovigilance. I don't have too much information about that. And I see a question here about.
Next question is being asked. Yes.
So we are not, the government here is definitely not going to recommend the Russian vaccine. I think there's a lot of concern with transparency on it. And the information that's coming out, we don't know what is real or not real. So I don't think that we're going to be readily able to adopt the Russian vaccine unless there's more information about it. So far what I've heard is that people are just concerned about the transparency, the safety of it, the numbers of people that were initially in the study. I think it was like under 100. So there was a lot of concern about how quickly they claimed that it was effective. So there is not a lot of appetite here to use it.
Right.
Yes, sir. I think that's all.
Still, that's all. Yes, sir.
Yeah, yeah.
Dr. Sandra, we have a very small token of appreciation for you from our department. So with your permission and with Dr. Haji's permission, I would like to show that in front of the screen if you permit me.
Yes, Sakhar, please share. Please share. Ma'am needs to stop sharing.
Thank you.
Okay.
Thank you. No, I think that's fine.
Yeah, it's a genuine advantage, ma'am. Because of this COVID situation, we could hear you people sitting at home.
That is.
Yeah.
Oh, thank you so much.
Thank you,
I
ma'am.
appreciate it.
Thank you,
I'm
ma'am.
going to take a screenshot of that.
Yeah, sure.
We're
Please,
gonna mail it to you, ma'am.
yeah, please.
Thank you.
Screenshot also taken, and we'll be mailing it to you, ma'am.
Perfect. Thank you so much.
Thank
Well, I
you.
hope we have the opportunity to meet in person in the future,
Yeah,
and hopefully
please,
we
ma'am,
will.
please keep in mind. Yeah, please, ma'am, keep in mind. We'll be inviting you. No problem. Please do visit India and do visit Kolkata. Thank you, ma'am.
That was great. Thank you so much. Stay healthy and stay safe, and hopefully we put this pandemic behind us soon. We'll keep our fingers crossed.
Thank you.
Absolutely, ma'am. Absolutely. Thank you so much, ma'am. Thanks for the lovely session, ma'am. It's our pleasure to have you today. Thank you.
So much. Okay. A good evening. Keep well.
Yeah. Good evening and good morning to you.
Good day to you, ma'am. Good day to you.
With your
Yes.
permission, we are ending, ma'am. Ma'am, we are ending the session with your kind permission.
Thank you so much, Ayo.
Thank you, ma'am.
Thank you.
Thank you, everyone. Thanks to all participants.